Right, so I think we'll make a start. Just somebody could give me a thumbs up that they can hear me and also that my slides are moving. That's great, perfect. Okay, so I'm just going to switch off my webcam because I think we were having network problems and the screen was freezing quite a bit as well. Right, so let's make a start. My name's Dev. I'm one of the acute frailty consultants, and the topic given to me by Anita is the integration of acute illness into chronic disease management and multiple comorbidities. So it's a bit of a handful there. It's a very different theme from what you've heard actually today to rheumatoid arthritis management, but I think the one common theme between that is the multidisciplinary team input and management. So we'll be talking a bit about that. Now, when I was given this topic, I was wondering about what exactly to talk about because sometimes we have specific topics where you could prepare, and I don't think we had a separate individual topic like this where we had a talk, but we used to, of course, practice and learn, but it looks like it's much more defined now. So I looked at your curriculum for foundation program training, and this is what it mentioned. So it's mainly what we'll be talking is about acute care skills, and that could be in the hospital or in the community, and also a more holistic approach as well, what you need to know and how you need to practice and manage our group of older patients when they present. So that's the curriculum, what it says. There's acute presentations, acute care skills, looking at holistic picture, including psychological, mental health, and what kind of an impact the social well-being of a person can have on their health, and the other way around as well, how their medical conditions can also have an effect on their functional capacity and further social well-being. So what we'll be talking through today, just a summary, is general principles about acute care and geriatrics, the common presentations which you'll be seeing when you clerk patients, when you're on the ward, when you're on the acute medical take. We'll be going through each body systems, not of course every single condition, but the most common ones that you'll be managing, especially on our care of elderly wards as well. And we'll also, I'll be talking about some common helpful tips, I hope, that which will help you and you're working as a junior on the wards as well. No talk is complete without talking about multimorbidity and the common medical conditions and how we manage them, what are the challenges that we face and how we can address them as well. So this all, if we have to sum that up in one word, is a comprehensive geriatric assessment. So when we come to the older person and managing their medical conditions and treatment, one has to look at the whole picture. Normally, we just concentrate on medical conditions, what their medications, how we can treat, but it is much more than that. So that's the kind of approach that you need to have whenever you're seeing these patients. The individual preferences is quite important as well. What are their views? What are the effects of the treatments? What is the burden like? What are we trying to achieve in terms of the goals? So you have to be very clear as to what you're trying to achieve and then communicate that to the patient and the family as well. Our focus is not only on treating these medical conditions, but it's also focusing on quality of life. And the reason for that is their life expectancy is quite different from somebody, for example, if they're much younger. So our focus is quite different, and no person is the same. So every person is quite different, and you really need to individualize your care based on what the individual has. Talking about hospital admissions, of course, the ones which are unplanned, there can be a lot of risks involved. Hospitals aren't the best places to treat our acutely unwell patients. You always have to consider the benefits or risks of any kind of care plan, management plan that you do. And then you'll have to always consider and keep in mind the component of quality of life as well, and what impact that can have when you're treating somebody. So what are the most common presentations that you normally see? So I think from years before, these were the classical, what we call as geriatric giants that were named, and they are as immobility, instability, incontinence, impaired intellect, memory. So it's a bit of an older terminology, and that's much more evolved now. So now I think they actually translate as frailty, which is the most common presentation, and of course our approach for our group of older patients, and not just characterizing them by their age, but based on their functional capacity and their frailty. And if there's any mismatch or deficiencies, uh, then they do present as unmet care needs, which is actually what is termed inappropriately properly as acopia or social admissions as well. Next is sarcopenia, which is, of course, the age-related changes in your musculoskeletal system, and any changes in those will result in immobility and falls, and not necessarily just related to their medical conditions, but uh, you have to think about what impact the aging itself has on our body systems. Next one presentation is anorexia of aging. Of course, once you've ruled out all the medical conditions for anorexia, you've got to think about frailty associated anorexia as well. So people can present with nutritional deficiencies because of poor intake, dysphagia, and so on. And they present as loss of weight and nutritional deficiency. So you've got to always think about how their appetite is, how their diet is, are they fulfilling their calorie intake and needs. The other most common presentation is delirium. And of course, it's much more associated in our older group of patients. This could range from mild cognitive impairment to dementia, and the flare-ups in the dementia, which could be delirium. So whenever you're managing our patients, there's always competing interests. You've got to think about the acute admission, the acute decompensation. What are your short-term goals, and how that evolves to more long-term goals, so once they're much better. And that's mainly about acute and chronic, managing these multimorbidities. Um, Patients might present with an acute flare-up in one body system, but you've got to think about what effect that has on different body systems, and thinking as a whole rather than just fixing the heart or just fixing the kidneys, for example. You've got to think about the impact on their quality of life. How is it affecting them functionally as well? So the physiological changes are quite different in our older group of patients, and the body systems interact differently. So they've got altered homeostasis, especially when they're acutely unwell, and that's something that you need to bear in mind. I think traditionally we've really approached as an individual organ or individual body system, but the body doesn't work that way. It works as a whole. So you've got to have a really overarching, overall holistic approach. Sometimes you can't completely eliminate the condition, because you have to choose the lesser evil. So the best example is if somebody's on anticoagulation and they're having falls, or they've had a clot and they're bleeding. So you really have to balance out and manage which is much more serious, and how you can, according to the time, treat individual conditions. So when you're doing that, it can be quite challenging, and that's when you take in the patient, keep the patient at the center of focus, and understand and find out what their priorities are, what's important to them, and what you can treat as well, because there's a lot of incurable diseases, chronic conditions that we have to manage. So that's how you decide on what to treat and what not to sometimes. Again, as I said, every individual is different. You might have to take a different approach, and you'll see a lot of variation in our specialty as well amongst different consultants and managing different ways. And more or less, I think everybody towards the end, we kind of go through a similar path. There might be some minor changes, but I think that's one of the challenges in our specialty as well. We've got sometimes limited evidence-based evidence as well, or research. So you go by your individual experience and your learning and the knowledge that you've had, and then you decide on how to treat the patient who's in front of you. The other point that you need to consider is older group of patients, they have an average life expectancy much lesser. So your focus of treating their individual condition is very different. You might not go for a whole group of tablets or medications which you're looking for prognostic benefit. It may be that there's very limited that can offer. So we'll be rationalizing, and we'll talk about this, rationalizing about the medications that they're on including polypharmacy. Now, there's a lot of advantages, of course, of modern medical therapy, and that's why the life expectancy is quite different to how it was before. But with that comes a lot of different set of problems. So whenever you're investigating or treating, you always have to consider the burden of these investigation and treatments, what kind of effects they can have. And unfortunately, sometimes the complications and side effects risk ratio is very different. And that in itself might cause problems rather than treating the original condition. So you've got to always bear in mind that there's a risk of overdiagnosis, incidentalomas, and picking up incidental things based on investigations. You need to be cautious about that. So before any time that you request, even it could be as simple as a simple blood test or X-ray or a CT scan, you've got to bear in mind what the pre-test sensitivity is. Will I get answers for the test that I'm doing? And that's something that you need to consider before requesting a test. I think the other point that's important is multi-organ failure. So recognizing when uh, when we're reaching the end. So that is end of life and palliation as well. So it's important to recognize early that unfortunately we've reached the end of the road, and then discussing that, communicating that with the patient and their family. That's the key. And that's where your communication skills really help you, and that's why you need to get skilled with that as well, because we end up in situations where you're just treating, for example, heart failure with the cardiorenal syndrome or cardiohepatic syndrome, where you're just trying to balance out and treat the heart, and then it starts affecting the kidneys and the other way around. It's then that you need to recognize that unfortunately there's limited that we could do, and try and optimize the number of years that the time that the patient has got left. Right, so now we'll focus a bit more on something that's really relevant to you guys, especially when you're working on the ward. That's the acute condition. So we'll go through some of the most common conditions and body systems as well. Some points that you need to bear in mind whenever you're considering treatment, when you're working as well. The direct and indirect effects of the management, investigations, and treatment, and hopefully some tips for you guys as well when you work on awards. So let's start from the top. I think we'll start with the nervous system. So delirium is probably the most common condition and presenting syndrome as well. This is a talk in itself, and I think one of my colleagues, or there's another separate topic for you as delirium as well. So I'll only be touching on the valid and important points. The way you need to approach delirium is it's a kind of acute brain failure, just as how we see acute on chronic decompensated heart failure or acute flare-up of IBD. That's the way you need to approach that. So it's a kind of acute brain failure, and it's a syndrome. So it's a combination of symptoms together as well, and the approaches, the presentation can be quite different. So that's the definition. It's the acute. So how would you find out that this is acute? The only way is by history, and that's why it's so important. And I appreciate the challenges of getting history, especially you're doing a night shift and at the middle of the night, 2:30, 3 o'clock, somebody's turned up, and sometimes you don't have that background. That's why it's so important at some stage to get some collateral history, find out from the care home, from the family, the friends, how that individual has been doing in the last couple of weeks, months, and so on. And that's when you get the more clear picture, and that's the relevance for that as well. Of course, a background of dementia makes you at more risk of delirium as well, but anybody can get delirium. Even a young patient who's cognitively intact can still get delirium, and we'll talk about that. That's based on the threshold of insult as well, but there's a more higher chance of you having delirium in dementia, and there is a bit of overlap between delirium and dementia, and sometimes it can be difficult. But I don't think there will be a great harm in overdiagnosing delirium. The problem is always underdiagnosing, because the themes and the principles of managing delirium is just good geriatric practice. So the key point here in delirium is attention. And that's whenever you're taking history, examining, talking to the patient, you will recognize that there are formal ways of assessing one's attention. That's counting back from 20 to 1 or the months backwards as well. And then the patients start and then they might stop in between. Or if they're so cognitively impaired that they might not even understand. So there can be an element of disorganized thinking as well, which again is characteristic of the delirium. And you would notice that the patient is fidgeting up and down, moving, restless, and so on. So that's more of a picture of a delirium. So it's the awareness, the conscious level that you need to be aware of. The important thing with the delirium is any of the acute conditions which I'm going to talk about can present as delirium. Delirium could be a primary nervous problem as well. Meningitis, meningoencephalitis could present as delirium. Stroke can present, and sometimes it can be quite difficult to differentiate that. But it's important to bear in mind that this could be a primary presentation of the central nervous system, or it could be a secondary of any kind of acute change in that individual. Another point to bear in mind, just this is probably a bit like a caveat, patients with Lewy body dementia, which is again another rare form of dementia, can have their altered consciousness or attention span, which will fluctuate. That is the classical definition. And the fluctuating consciousness with delirium, that is more characteristic of delirium, but you can get that in Lewy body dementia as well. I think the threshold of insult is directly related to delirium, and what that means is that if a younger patient presents with delirium, it may represent a more serious condition that they have. So the threshold will be much higher. So if the insult is much higher and they've got delirium, then their prognosis and outcomes can be quite poor. So it's important to recognize that. But anybody can present with delirium. As I was saying, if you've got underlying cognitive impairment or dementia, there's more higher risk of delirium. So there's lots to talk about that, but those are the main points which I wanted to just relay to you as well, because otherwise it would be incomplete if we don't talk about delirium. Next, we'll go on to respiratory, next body system, and the most common presentations on a respiratory or even our wards as well are these. So that's COPD, ILR, and bronchiectasis, cystic fibrosis, recurrence of TB, although those are a bit less common. But those are the main presentation, and they have similar themes as well in terms of the treatment. So what are the common challenges that you can face when you're treating these patients? Especially in our group of patients, older patients, you'll find out that they have underlying abnormal rhythms, they're more tachycardic. You're trying to treat the acute flare-up of the COPD or ILD with salbutamol, they become quite tachycardic. So it's a bit of a balance, and you need to adjust and adapt your management plan based on their heart rhythm as well. So you might consider an alternative and go with Atrovent, but again, that also has its own side effects and problems, and that's why it's important that you change your plan, and then you review each day as well, and try and keep the medications to the minimum. So if person is much better and they're not wheezy anymore, you could consider stopping their nebulizers, and that's what you need to bear in mind when you're doing your ward rounds. Do I need to continue with this into a medication? Can I stop it? And that's generally your approach to these conditions as well. Try and always start slow and keep them to the minimum as well. There are some exceptions to that with certain drugs, but as a general rule, I think that's a good approach to have. Other things that you need to bear in mind, I think conventionally when we had single organ pathologies, we used to try and make a unifying diagnosis based on the symptoms, and that's still a very valid approach. But again, in an older patient, you have a lot of overlap. They've got multiple conditions, and sometimes it's difficult to recognize what exactly is going on. It could be a combination of things, and I think the approach would be sometimes to have a more generalist approach, diuretics, antibiotics, nebulizers, and so on, and then try and tailor your approach, and then see what's the most likely problem that's being caused here. And there's a lot of overlap between COPD and heart failure. Sometimes if patients aren't getting better, they're still hypoxic, still wheezy, then you can consider some diuretics as well, because they might have cor pulmonale as a result of their as a result of their COPD. And I think sometimes investigations, the threshold, you reach that threshold where you need to do some further tests, for example, BNP, echo, or CT, which will guide your management as well. The mainstay for all of these conditions is steroids, and I think Paris also mentioned about steroids very briefly as well. In our specialty, again, we try and keep them to the minimum dose possible, the minimum duration possible, and there are acute side effects that you need to be aware of, and also chronic as well. So when we're talking about acute, whenever you start these steroids, you need to be aware of what the conditions, and also sometimes we tend to miss or forget to inform the patient as well about the possible side effects. So whenever you start somebody on steroids, think about the PPI. Do they need them? What kind of protection do they need? And sometimes you start steroids. For example, the other day we had somebody who had SVC obstruction and that needed steroids, and perhaps we started a bit higher dose than would be appropriate for her, and unfortunately she suddenly became delirious and psychotic as well. So it's probably dose dependent. Try and start at a lower dose, and you can slowly pick that up. But important to recognize that could it be steroids that's causing the problem as well. And quite often in delirium, you can have a combination of things. So you can't just attribute one cause for the syndrome. You've got to think about multiple things and have that kind of approach from different ways. The other thing that as soon as somebody's on steroids is that you need to find, first of all, locate that blood sugar chart and see what the blood sugars are like. And then get again diabetic advice if required as well, and keep that to the minimum. You can get different symptoms, of course, due to hyperglycemia, so just to bear in mind of those symptoms. When you're doing those blood tests as well, it can cause leukocytosis, increased white cell count, neutrophils. So it's a bit, sometimes there's an overlap between the infection and the white cell neutrophil count. So sometimes you can attribute it to steroids. So something to bear in mind. And based on that, you can rationalize the duration, the course, the dosing of antibiotics. So just have a think about what could be the chronic side effects from steroids. And this is another picture just showing about the wide. I don't know how well it projects, but I hope you can see the main side effects that can affect the whole body, right from the top to bottom, including skin, neurological, cardiovascular, as that picture shows. So you can also get steroid myopathy, and that's mainly proximal myopathy. So whenever you're in your MDT meetings, if you're having a lot of input from the physio and they're saying that that individual is struggling to mobilize, do they have proximal myopathy? Again, this is probably related to chronic, so it'll be in a clinic kind of setup. But you've got to bear that in mind and always review the indication and duration of steroids, and can you cut down, can you stop that? That's always what you've got to bear in mind. The other major thing is osteoporosis as well, whilst we're talking about musculoskeletal systems. So we've got different risk score calculating scores that we can use, and then try and prevent osteoporotic fractures. So checking their vitamin D as well is very helpful. So that's to do with the respiratory. We'll go on to cardiology or cardiovascular system, and again, our mainstay is heart failure. You can have mainly two types now, which is HFpEF and HFrEF, and that's mainly based on the findings of the echo, whether they've got preserved ejection fraction or reduced. In preserved, there's also indirect markers that you can see on the echo findings to find out whether it is preserved. And the mainstay of a preserved ejection fraction heart failure management is managing those comorbidities. So that's very relevant to today's talk. When you're managing the heart failure on the wards, again, you need to decide what is their dry weight. Can they still manage with the degree of swelling in their legs, for example? How much is too much? And again, you need to individualize that based on the patient. But you have to work with some risk as well. You need to appreciate that there will be some risk with our patients, and it's about communicating that to them and their families as well. So you need to balance out again what the effect is on the renal impairment. Most of these cardiac drugs are nephrotoxic, but it may be that they're, because of the decompensated heart failure, that they're getting acute kidney injury. So as soon as you diurese them, they actually sometimes their renal functions get better. And again, it's a balance, as I was saying before, between how much of you going to diaries and how much of renal impairment you're comfortable with. And this is where multidisciplinary teams really help. And you can get the heart failure team who've got expertise in this to assist you as well. Some people prefer boluses of diuretics and some people prefer infusions. There's again benefits risk for both sides. Boluses, if you give boluses, then people aren't attached to machines and you can try and mobilize them better, get them rehab a bit earlier and potentially reduce their length of stay. On the other hand, infusions, you might get better diuresis and maybe not as much as a hit on the kidneys as well. But again, they're attached to machines, so that could potentially be a barrier for their mobility and enabling their mobilization. There's a lot of medications that one can be with reduced ejection fraction for prognosis. So if you've got reduced ejection fraction, then the medications are more beneficial. So you would tend to see a lot of medications, and that's fine. But in preserved ejection fraction, again, it's not licensed. So you only give the tablets that you're going to benefit from and achieve good quality of life. So that's something to bear in mind. Other common things that you'll see on the ward is antihypertensives and trying to manage supine hypertension versus orthostatic, and that can be a challenge and of course a falls risk. So you try and balance out each tablet and see their progress, because people, as soon as they start recovering, their reserves and homeostasis kind of balances out as well. So you give them time and then decide on regular reviews how much to give and what to stop. Just to bear in mind as well, beta blockers, they can cause sleep disturbances and of course can exacerbate asthma, although quite rare in terms of COPD. But asthma, I think we tend to avoid them. But compliance can be an issue, so you would have a low threshold to stop that tablet, even though there's prognostic benefit. Other challenge which you'll commonly see when you're doing blood tests is hyponatremia, and you need to assess the fluid status and then decide which way it's going and how much you can achieve and how much you're comfortable with as well. Monitor which way it's going so you can adjust your diuretics as well. The other challenge that we see in clinics is that people with heart failure, because of the diuretics, they have urge incontinence or urge symptoms as well. They have overactive bladder, so it really affects their quality of life. So again, getting that balance between both of those symptoms can be quite helpful. Just a note on valvular heart diseases as well. As geriatrics or geriatricians, we try and give an opinion about managing these patients and also commenting on their fitness as well and their risk and side effects. So we do some discussions with cardiology as well, so like a cardiogeriatric liaison services to try and optimize their management and consider them for TAVIs. This is one of the most common challenges that we have. I'm sure everybody would have experienced this if they worked on our wards. That is the anticoagulation, the bleeding risk and the fall risk. So I think the general consensus is that we probably will be more proactive to anticoagulate somebody, even if they do have falls risk, unless the burden is such high and they're having repeated admissions for scans, or the patient declines that, and that's perfectly fair. And that's where you need to get them involved. As I was saying, polypharmacy is an issue, but not so much with preserved ejection fraction. You have a bit of more room or liberty to stop those medications because of limited benefit. We've got some newer tablets, well, not necessarily new, but we're already using them for diabetes. But we've got dapagliflozin and SGLT2 inhibitors that can reduce hospitalization and mortality in both HFpEF and HFrEF. So there is some hope for the future. Right, next, very briefly, we'll talk about a digestive system. That's inflammatory bowel disease, the most common acute conditions in the digestive system. It's mainly inflammatory bowel disease. And again, the mainstay is steroids. We talked about that. Just to be aware of dehydration, the older group of patients are more risk of that. So you might to give some more IV fluids, and you need to balance that out, as I was saying, because it could potentially affect their thirst, and it might be difficult to get them off fluids. but that's what you need to review. They do present with bleeding, but there is a high risk of clots, so you would probably be more to give prophylactic VT treatment as well, even though they're bleeding, and to be aware that most of these patients are anorexic and more risk of nutritional deficiency, especially refeeding syndrome. And dietitians can help as well. So we're coming towards the almost the bottom. So I'll talk about the urinary symptoms, and the most common presentation, probably more overdiagnosed than we should, is UTI, because again, it's about that recognizing that changes in the older patients. I think we struggle with those diagnoses and just kind of label UTIs. But there's a lot of asymptomatic bacteriuria present in our patients, and that's something that we need to recognize. Constipation, although it might sound that it's quite trivial, it can have a massive impact for our patients as well. Constipation can cause urinary retention and then a risk of infection. So it's that kind of algorithm or the pattern which happens. So preventing that can be very beneficial, and all this leads to delirium. So you can see that the knock-on effect that can happen from a simple thing as constipation. If they have an increased frequency of urine, it could be due to hypoglycemia, high sugars as well. So it's not just UTI which causes increased frequency of urine. UTIs, infections, they can have a massive impact on their mobility as well, especially patients with overactive bladder who have urgent continence. They rush and then unfortunately they fall. They have orthostatic drops. So it's a combination of things which leads to their falls. That's something you need to bear in mind. In the women, females, of course, they can have atrophic vaginitis, and estrogen or estradiol creams can be used, and that's, I think, the only thing that will help prevent recurrent UTIs, if indeed that is present. Overactive bladder, we briefly talked about as well. Again, that is a very comprehensive geriatric assessment, which is essential, and that's a different topic on its own. But you need to bear that in mind with the presentations with urgent continence, increased frequency of urine as well. Sometimes it can be a bit of a debate between urology about duration and prophylactic antibiotics, but as a geriatrician, I think we're not too pro with that as well, because of the limited benefits and more risk of trying the antibiotics, increased resistance and limited benefits as well. So perhaps the best way is to keep oneself hydrated. In men, you're probably more high risk if they've got any prostate problems as well. So this is a slide. You might not be able to see that completely, but it is from the Royal College, and they have come up with this algorithm. It's just helpful for you to refer, because if you are in doubt sometimes whether to treat as a UTI, especially with our patients with the limited history, cognitive impairment as well, it can be challenging to diagnose sometimes. So you take all of these factors into consideration before you treat somebody for a UTI. So it's a helpful guide to follow and to assist in terms of management. And it's not just including UTI. If you see here, it also includes about delirium as well. What are the triggers and how do you manage and prevent? So that's the mainstay for actually preventing UTIs and managing them as well. Good. So I think we're coming to the end of the body system. So next one is musculoskeletal system. You might work on orthopedic or orthogeriatric ward if there is any facility of that. The mainstay again is fragility fractures, and you'll mainly be seeing hip fractures on orthogeriatric ward, but other fractures you can see on a geriatric ward as well. It's important to have a comprehensive assessment in falls, and it should be treated as a syndrome rather than a symptom as well. I think the one that we're not doing very well is bone health protection, and you assess for the fall, you manage that, and then you get all your multidisciplinary team involved, including adult social care. But we tend to forget the bone health protection and doing those risk assessments as well. I think there's an audit going on right now about that and trying to improve that care. So we are working on that. Next, just a note on silver trauma, which is recognized. So even a trivial or minor trauma injury can lead to massive effect and multiple fractures in our group of patients because of frailty. That has been recognized, and there's now more specialist centers who can manage silver trauma as well. There's a lot of working that we need to do with multidisciplinary teams, different specialties, and our input is very helpful in getting good outcomes for our patients as well. I think the most frequent thing that's asked when you're on the wards is, can we mobilize this patient? And I think most of the times the answer should be yes, unless there's some very strong contraindication, they've broken certain bones where they can't mobilize, or they've got cord compression, or they've got a very so unwell that they've got an unstable hemodynamic instability due to arrhythmias. Apart from that, I think the onus or the push should be to mobilize them early as soon as possible, and try and reduce that barriers as well. And that could include a catheter or cannula or oxygen nasal cannula as well. That's the things that need to go in your mind whenever you're doing a ward round. Does that patient need that? Can we switch that off? And it's just pushing that during the MDTs that can achieve so that you can achieve good outcomes and reduce length of stays. And yeah, that's what I mentioned there about MDT working. I've just included this slide, which I tend to read a bit as well on the MDT podcast. There's a website, and this kind of summarizes all the trauma, the topic of trauma in our group of patients as well. So the over 75s, major trauma can cause multiple injuries, and the outcomes are not good. And I think we're trying to improve those outcomes. And the only way to do that is to recognize and manage them well. Not all fractures are osteoporotic. If there's a fall from a standing height, that is the most common mechanism of injuries, and they have a fragility fracture, then it's almost certainly osteoporotic in nature. So that's how you differentiate between osteoporotic and non-osteoporotic. And the trauma is not just limited to bones. It could be neurological, it could be musculoskeletal as well. So it's important to recognize that. So yeah, if you manage trauma well, their outcomes are very similar to younger, and that's a quite striking point, because you wouldn't expect that, but that's the evidence that we've got now. So it's important to recognize that. So what I talked up till now is all comprehensive geriatric assessment, and that's why I kept this slide to the end. When I was training and I came across this term, I didn't know what it meant, and there's a lot of it. Just felt like a group of words, but now I can understand what they mean by all interdisciplinary, multidimensional, creating these problem lists as well, supporting rehab, supporting long-term care. Getting adult social care involved as well, getting their intrinsic capacity, which includes friends, family, anybody. We've got voluntary charities as well who do help out, and it's getting those resources for our patients. Why do we have to do this? Why is our approach different in older patients? The evidence for that is here. And if you can, it's very likely that with the CGA that you do, it's more likely that patients can be alive, so you're extending their age expectancy, and also they'll live in home for 6 months long after an acute illness. Otherwise, they become more care dependent, more frail, and unfortunately unhealthy as well. So that's the evidence for CGA. It's not only just frailty and functional, but it's also cognitive. You can maintain their cognition as well, so the decline rate is much lesser, mortality rates is much lesser if seen by a geriatric team. Our focus should be getting MDTs, that's different therapists earlier involved, and this is where everybody can work together to find out what they're, because otherwise it's just we're trying to treat the medical condition, but we've kind of missed the boat, sorry, as how the individual is managing. So the sooner we get that information, whenever we're communicating to the patient, family, friends, if we find that out sooner, the better it is and the quicker it is as well. You can provide good quality care. Getting those walking aids, getting those glasses, hearing aids, dentures, everything in will just enable better care, and we can avoid all the potential problems because of immobility. Pharmacy review as well, having pharmacists, we do also virtual ward round. and we have a pharmacist there, and it's very helpful to have them because they normally have more knowledge than us and can help us, especially if you're trying to cut down wean doses and trying to continue that in the community. Sometimes it can get lost through a GP, but having a pharmacist is very helpful. Again, part of delirium management, or for any comprehensive geriatric care for that matter, as I was saying, nursing staff can help as well to decide whether they need bed rails or whether cannula catheters can come out. So I'm going to leave you with this slide. I just want you to have a read about this. If you can't, because of the font is quite small, I'm just going to read this out. So this is from the Wessex Science Network, and about their experience with the comprehensive geriatric assessment. So there's a 81-year-old gentleman who was referred to the rehab MDT. He had recurrent falls, trips, poor balance, and excess alcohol problems. His his general health had deteriorated since the diagnosis of dementia of his wife, and he was also quite depressed. And that was having a massive impact on him as well. He had increased care demands, and he was needing help. That's what the presentation was. His past medical history included hypertension, chronic kidney disease, asbestos-related plaques, and depression. So there's a second part to this, but I just want you guys to have a think about what the main theme here is, what the presentation is, and how you would manage that. So just a couple of seconds for you to think about. Okay, so this is the next part of his journey. So the main theme was around his mood, as in his mental health, and and his social care needs as well. So coming to his past medical history, he needs a pharmacy review, so to review all his drugs, does he need them or not? And as I was talking about bone health, that's something that we tend to miss, especially for these patients who come in with falls. So they arranged for a DEXA scan to review whether he's got osteoporosis. He had a risk factor, of course, of alcohol as well. Physio rehabilitation is absolutely key here. So with the alcohol, you can have musculoskeletal involvement as well, poor nutrition, and weak muscles. And that's why you need strength and balance exercises. And that's just a reflection of how falls is a syndrome. Communication is key here. So they communicate to the family. What support system did he have? Main is the alcohol and the mental effects. So try to cut down on his alcohol. What impact that had on his quality of life. So again, he was going to the loo quite often, and then he was depressed. That has a direct effect. And also, he'd lost confidence because of his falls. So that's what was addressed in terms of trying to cut down on his alcohol, having that support system. So you've got different companionship, befriending services that we can access as well, trying to get them involved and support him, and having that taking that time, I think, with them and having a clear vision and goals and plans. So they gave him calendar as well to have to motivate him, which was certainly help rather than just adding in tablets for depression. Regular exercises also was achieved, and again, this is like a group working, so the potentially similar patients he could be in touch, and that could help with his mental health. Unfortunately, he did further present to ED, and that's something to recognise because we have a high readmission rate, and sometimes they're just discredited as simple things or failures, but actually it's just the nature of the aging. So he did come back in. He did need some help, but he was the length of stay had cut down, so they had quickly made a plan from emergency department itself to the frailty services in the community and potentially avoided that admission. And again, if you've got that set up, then it's very good, and you can really achieve good outcomes as well. He was supported indirectly, of course. His wife was supported as well, and that's how that was achieved. And this is overall a good outcome and a good journey, good case study to read. It has to be recognized by all specialties. So and of course front end, not everybody will have an acute frailty unit or based or acute frailty in ED, of course. So it's increasingly recognized. This is from RCP that regarding acute medicine about a toolkit that one can use, and it doesn't necessarily has to be a geriatric or geriatrician team. So it's a vast topic, but if you keep these kind of topics in the back of your mind, like a checklist almost, whenever you're seeing our patients, then you can create like a problem list and address that. So if you bear in mind these topics like medical, mental health, functional capacity, social circumstances, environment, so it's a really holistic kind of picture there. And if you kind of tease out each thing, you'll cover a lot of bases, and then you'll get really good outcomes for our patients. So this is again a good domain, a good list for CGA. There are different campaigns which are available to try and push with improving outcomes, and this is another poster which is quite helpful to avoid deconditioning in our patients, especially when they're admitted. It's regarding falls, have they got all their aids, how are we supporting them, encouraging to mobilize and go to the loo. There's some places who also recruit feeding assistants as well, because unfortunately the nursing staff are so busy. They do need support as well, and it's only when we achieve all of this can we get good outcomes. And you can see here all the aids: calendar, time, orientation, glasses, hearing aids. You need all of that to try and ensure and get good outcomes. This is another campaign as well. You normally see people, patients in gowns, and they've got delirium. It doesn't certainly help for their normal routine. It doesn't help for their orientation as well. So trying to get the families involved, joint assessments, getting their normal clothes as well, so that they are aware what's going on, getting there in their normal routine is quite helpful. This is just a slide to summarize the whole multimorbidity. The main components of multimorbidity is stated here: the physical, mental, what the symptom complex, that's disease burden, impaired sensory input as well, which is again a cause for the falls. Alcohol, as we talked about, can have a major role, and of course learning disability. So this is how you would characterize somebody with multimorbidity. Multimorbidity and frailty are very closely linked, but they can be independent as well. So you take these points in mind. So after this, talking to about the future, as I said, I think hospitals aren't the best places. I think community setup is perhaps better, and we've got different places who have trialed and been practicing hospital at home. So seeing patients in the community and managing the certain conditions is perhaps more beneficial for the patient, and better outcomes as well. We want to prevent those adverse effects in hospital, and that's how you can achieve that. We also do virtual ward rounds as well. So we've got frailty practitioners in the community who liaise with us and do CGA, and we give our consultant input. Next point, we've got a big cohort of patients as well who are in care homes, trying to improve their care, and linking up with the GPs in community can be a good avenue to improving care. And of course, next day emergency services or emergency care services, similar to the SDEC setup, can be quite helpful. So that's about it. That's regarding multimorbidity, acute conditions in the older patients, and management, and the common tips or common points that can be helpful for you on the ward. Early mobilization, and trying to get really involved in those MDTs to get good outcomes for our patients. And yes, so I think with that, that ends my talk. Any questions or comments? Nope. Okay. Well, I hope this was helpful. It was quite a comprehensive talk by myself and parents as well. Yes, and if anybody's interested, of course, in geriatrics, then please do approach us, and we can give you a bit of good guidance as well. Good. Excellent. Thank you very much. So I'll end this talk. Thank you. Thank you. Yeah, yeah, yeah. They have, they're like commenting on the chat box. Yeah, yeah.